Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone, and welcome to today's session organized by the Saudi Neurology Interest Club. My name is Natia Bikari, co-founder of the club, and I have the honor of moderating this lecture. We are truly delighted to host Dr. Faisal Althekair, a distinguished neuro-ophthalmologist and neuroimmunologist, consultant at King Abdulaziz Medical City, and Associate Dean of Postgraduate Affairs at King Saud bin Abdulaziz University for Health Sciences. Today, he will be delivering a lecture on approach to double vision. On behalf of the club, I would like to extend our sincere gratitude to Dr. Althekair for taking the time to share his expertise with us. This is a valuable opportunity for all of us to deepen our understanding of an important clinical topic. We encourage everyone to stay engaged. If you have any questions, kindly type them in the chat box, and we'll address them during the Q&A session at the end. Without further ado, it is my pleasure to welcome Dr. Faisal Althekair. Doctor, the floor is yours.
Thank you very much, Nataline, and thank you for the organizer committee for their invitation, and hopefully that you'll have an enjoyable session. Thank you all for your presence at late this afternoon. This reflects your interest in the field of neurology, and we today will be talking about approach to double vision. Just 1 second. Okay. So I'll take a moment and try to hold your fingers 30 centimeter away from your eye, and do not look at your finger. Try to look at the screen you're seeing currently. So by doing this, you will be focusing on the screen, and you may see the finger fluttering around, and you may not. But if you not, you can see it later on. And this is an idea about how the patient will see in double vision. Why is that happening? Because when you look at the screen between your fingers, one eye only able to look at the screen, the other eye is misaligned. So with the eye that's able to see in between your fingers. So you might see your finger floating around, and this is called actually finger floating illusion that was described first in 1930s, and I took it here as an example of how normal patients will see, a normal person will see, perceive double vision. The description of double vision is not always as two. People who may have double vision, I see some typing in the screen, but anyways, people on double vision, they might describe that seeing haziness or shadow, like the picture here on the left, or they might see the words are into each other or above each other. And sometimes they might see split pictures, like forehead as two, or you have two eyes. So not always the case that the patient will come to you and tell you that I'm seeing two pictures. And it's our job how to approach this complaint of double vision and analyze it using our neuroanatomical knowledge, history, and physical examination. As a neurologist, we got more interest in double vision when it is binocular. For example, what I mean by that, we see double vision when you, when you cover either eye, you will see a single image. So binocular double vision is the double vision, you see it due to ocular misalignment. In normal situation, both eyes will be looking at an object and both will be reflecting to the macula. But for any reason, if this eye is misaligned due to third, fourth, or sixth nerve palsy, this eye will see an image, and this one will see another image. ما أسمع صوتي واضح الآن. أوكي، صوتي
اي
واضح ولا؟
نعم، اي نعم
جيد.
دكتور، صوتك
أوكي.
واضح.
So, for any reason like sixth nerve palsy, third nerve palsy, the patient will have an image seen by this eye and another image will be seen by the other eye. So when you cover either this, you will see single, or this one, you will see a single. And this is what we are interested in neurology. Because even if you have an ocular or monocular double vision, you can have it if you have an refractive error. So this patient will go to ophthalmology. So looking at all cases of double vision, which comes to the emergency room, we find a lot of causes that might cause double vision. Going from the most common causes, which is microvascular, which can be seen in diabetes, decompensation. And decompensation, I mean here, the patient can be born with some kind of ocular misalignment, but they are always compensated during their life. At one point of their life, this misalignment might be decompensate and the patient will perceive double vision. Those causes are not serious at the one on the box on the right that we don't want to miss, for example, aneurysm or stroke or a tumor. Therefore, our approach should be starting to localize where is the pathology. We cannot know the cause of this double vision, whether it is microvascular or a tumor or aneurysm or a stroke, without localizing where is the problem. This is applicable to all symptoms in neurology. We go to where, then what is the problem. And with the next slides, I will be reviewing some points and relevant neuroanatomical localization, history and physical examination, and we'll go through over some cases. So, what is the control of eye movement? How our eye moves? So we divide the control of eye movement into two types, the supranuclear or internuclear. Can see here the picture on the left. This is the brain, and this is the frontal eye field, and this is the parieto-occipital loop, and then through the brainstem. So it looks complicated, but when we divide it, we can divide it into fast eye movement, which is saccades, or slow eye movement, which is the pursue, or and the third one is the VOR, which is vestibulo-ocular reflex. All these are called supranuclear control of eye movement. And of course, there is an internuclear connections. One eye or a sixth nerve cannot move one eye to the right. It has to call the other eye through the medial longitudinal fasciculus so they can move together. So this is the internuclear control. An example of this, the internuclear ophthalmoplegia or stroke or skew deviation. And the journey of infranuclear is well known to most of you, and like control of third nerve, you can see it on the red, or fourth nerve, or sixth nerve. And then after the nerve, there's a neuromuscular junction, in which cases like myasthenia gravis or thyroid eye disease, they can have double vision. Muscle disease, for example, thyroid eye disease or myositis can cause double vision. So uh, our job is to localize where is the problem in the patient, with the patient coming with double vision. Is it in the nerve? Is it a neuromuscular junction? Is it a supranuclear problem? By now, I know that most of you know the innervation of extraocular muscles, but briefly we'll go over them. All of the muscles of the eye are supplied by the third nerve, except for the lateral rectus and superior oblique. So if you have a third nerve palsy, only the lateral rectus will be working with the superior oblique. So the eye will be deviated outward and downward, I like the picture here, which is a typical case of third nerve palsy, but not all of them will come to you saying, hey, I am third nerve, so diagnose me. So some of them will have partial third nerve palsy, in which we will need to further examination to identify this. Superior oblique will cause intorsion, that will supplied by the fourth nerve, and the patient will come to you saying, hey, I'm seeing double when I go down the stairs. because when you go down the stairs, you need to look down and inward, and that will the cases of fourth nerve will come to you. In sixth nerve palsy, the eye will be deviated inward. Point about cavernous sinus versus orbital apex syndrome. If the patient, sometimes they can come with a frozen globe. So the one eye is not moving. All the nerves go after leaving the brainstem, going into the cavernous sinus. They gather into cavernous sinus in this way. You can see here, third, fourth, and sixth nerve near the internal carotid artery. So if you have a lesion in the cavernous sinus, you might have a frozen globe, and that might affect also the V1 and V2 distribution of the sensory part of the face. And what is the difference between cavernous sinus and orbital apex syndrome? In orbital apex syndrome, where you have a lesion in the orbital apex and affecting near the superior orbital fissure, will involve also the optic nerve. So the patient will have a frozen globe plus vision loss. So to differentiate between the two, vision loss is supporting more of a superior orbital fissure syndrome. Few words about the supra and internuclear control of eye movement. I'm sure that most of you are familiar with the third, fourth, and sixth nerve palsy and the infranuclear, but the supranuclear control, just I will talk about it briefly. So we have the frontal eye field, which is controlling the saccades, and pursue, which is slow eye movement, and the VOR also involved in the controlling the eye. So what are the types of supranuclear eye movement? The saccades, as I mentioned, it is a fast eye movement, and it has a place in the brain, which is the frontal eye field, and it goes for horizontal saccade to the pons in the area of PP called PPRF, parapentarine reticular formation, and for vertical saccades it goes to the midbrain. Pursue is poorly localized, so this is a slow eye movement. So when you examine saccades, you ask the patient to look right, look left, look up, look down. This is a fast eye movement. And by that, you're examining those areas. Versus pursue is very slow movement. You focus more on third, fourth, and sixth nerve, not only on the supranuclear control. VOR is something that it is important in our life. When you move your head to the left, automatically the eyes will move to the right. But because you're conscious, you can control your eye. This will not happen. But in comatose patients, for example, where they don't have a control on their eyes, you can see this by doing the vestibulo-ocular reflex. And vergence is like something that convergence has a different pathway in the brain. I will not go too deep into that. Let's take this example for horizontal saccades. This patient having double division horizontal. When you look to the right, you can see a limitation of adduction here. When you look to the left, you can see limitation of adduction also on the right. Let me repeat the video. The patient looking to the right, let's stop it. You can see here limitation of adduction. What is the problem? Is it a third nerve palsy? No. We'll see why no. Um, and here you need to understand the supranuclear control of eye movement. The frontal eye field on the left side supply the PPRF and nucleus and abducent nucleus, which calls the lateral rectus to move the right eye to the right, but through the medial longitudinal fasciculus, that will call the third nerve on the left to follow it. But here, there is a lesion in the medial longitudinal fasciculus. That's why the patient able to move the right eye, but not able to move the left eye inward. And we call this internuclear ophthalmoplegia. I saw this in the website. Thank you for the group for posting the etiologies. You can review it after the lecture, and the etiologies causing internuclear ophthalmoplegia. This patient has binocular ophthalmoplegia, which can see in patients with multiple sclerosis. That's why also that's explained if you have a stroke in the left side, in the left hemisphere, the patient will not be able to look to the right, and then the patient will look to the left at the site of the stroke. So you saw left MCA stroke, they have this patient eye deviated toward the side of the stroke. This is in horizontal saccade. Vertical saccade, it's localized in the midbrain. Sorry, I didn't mention here one point, the differentiate between internuclear ophthalmoplegia and third nerve palsy. This is the patient. Why not having a third nerve palsy? Because now, when you see the video on conversion, like the patient will look into the examiner fingers, the patient will be able to adduct, and this is because the pathway is coming from conversion pathway, so the third nerve is normal. So the problem in the medial longitudinal fasciculus. Vertical saccade localized in the midbrain, not in the pontine. And if you have a problem there, the patient will experience vertical double vision, such as in cases of, for example, a stroke. This is an example of pineal gland tumor pushing on the midbrain, causing vertical. A patient will not be able to look upward and might have vertical double vision. Going into history and physical examination, if you have a patient coming to you with double vision, the first question, as I mentioned earlier, you want to know if it is binocular or monocular. Disappear when you cover either eye, because in monocular, you can have it in ocular surface disease, dry eye, refractive errors, retinal pathologies. They might have double vision, and in that case, you refer to ophthalmology. So that's the key entrance to when you approach double vision. You don't want to go into differential diagnosis, localization, and the patient having only monocular double vision and the problem in the eye. Okay, the second question, is it the double vision you're seeing, is it vertical or horizontal? Why is that? Because you can narrow your differential diagnosis. In vertical double vision, in the second part of the slide here, you can see it to nerve pulses such as fourth and third. You can see it in myasthenia and thyroid eye disease, or in the one they talked about, is skew deviation, which is reflecting the vertical misalignment due to pre-nuclear problem. So few differential diagnoses in vertical double vision. And the point here also that myasthenia is a differential diagnosis for any, like vertical or horizontal, you can put myasthenia gravis. The third question, is it intermittent versus constant? Because if it is intermittent, or like cases of myasthenia gravis usually get worse at the end of the day. And it can. Sometimes it can be persistent, but worse in terms of separation of images. Decompensated phoria. What I mean by decompensated phoria, the patient will be born by misalignment, and then at the end of the day, they will be tired of compensation. They will might have um, double vision at the end of the day. And one of the things that I got from the resident or the trainees, or the double vision is the patient started to have a sudden double vision. Usually, the sudden word is not applicable to double vision, because it's always sudden. It's always starts at double vision. There's nothing like called gradual double vision. So, repeating the question, monocular double vision versus binocular, horizontal versus vertical, intermittent versus constant. Then, is it worse on either which direction gets worse? For example, six nerve palsy, because when you look at the distance, you need to abduct the eye. You need to use your lateral rectus. So that will give you a hint of six nerve palsy. Also, six nerve palsy is get worse at the direction of the nerve palsy. Yani, for example, if you have a six nerve palsy on the left, you go like, it's worse when I look straight ahead to the far object and to the left. So that's give you a hint of the diagnosis. to near, for example, that third nerve palsy can be worse in the near, um, or accommodation insufficiency, which is part of decompensation. Portion down the stairs with the cases of fourth nerve, as I mentioned earlier. All right, so we took the history of patient with double vision by taking the details of it and try to knowing where is the localization. After that, you need to ask about the eye itself, if there is any droopy eyelid, pain with the eye movement, headache, that will sometimes give you a hint of the diagnosis. And then you do a neurological review. So if the patient have weakness on the right side, you know that might have a brainstem problem. The left third and right weakness that might give you one of the stroke syndromes. So review always the neurological review for weakness, sensory problem, dysphagia, etc. Followed by systematic review, for example, giant cell arthritis, ask about weight loss, fever, etc. And by that, you finalize the history taking and you try to think by taking the history, sometimes you get your answers. When you go to the examination, you need to do the afferent examination. I mean, by afferent examination, doing the visual acuity, visual field to confrontation before the efferent examination, before the third, fourth, and sixth nerve. Why is that? Because you don't want to be biased by if the patient doesn't see with one eye and then it is deviated because he doesn't see, not because he has a third nerve palsy or it's decompensated. He cannot do the conversion. So it's good to have the habit to do afferent examination before efferent. Look for the patient eyes. Look for proptosis. This patient has thyroid eye disease. You can see how the iridness and lid retraction on the image below, and that can give you a hint of the diagnosis. So look for proptosis. Look for ptosis. And this patient have ocular myasthenia. You can see here the left eyelid is droopy, and upon lifting the left eyelid, the right eyelid dropped down, and we call this curtain sign. Why is that happening? The patient here, they're trying to elevate the left eyelid, and more innervation coming to that eyelid. But the brain cannot give innervation to, by hearing low, it cannot give the innervation to one eyelid. So it gives the innervation to both eyelids. You can see here the eyelid is retracted. When you elevate the left eyelid, automatically the right eyelid will come down because the less innervation needed now. So that's the idea of curtain sign you can see in myasthenia gravis. Look for redness or corkscrew vessels. This patient who has carotid cavernous fistula or cavernous syndrome, they might have this redness in the eye. So that's something to look for before doing the efferent examination. When you do the efferent examination, you know, like I know that most of you do the H shape, which is ocular vergence. So both eyes is used to do the H shape, but there is also the ocular duction by doing each eye separately. And then we mark what is the deficit. You see here, for example, here is all 0, 0, 0, here -4. That means the left eye is not abducting at all. There is 100%, 0% movement. So it's called -4. Why we grade it in our clinic? Because we want to see if it is improving. The patient have sixth nerve palsy who comes to you after 1 month. We don't know if he still complain of double vision. But when you examine him, you see that you documented that there is 0% and now it's 50% moving. So the patient is improving. So something is to have a good habit at the early of your career to document if there is what is the degree of limitation. So that's usually done by off the resident, neuro resident, and we do it here at National Guard. But I hope that in future career you document how much is deficit. For example, here by -4, not moving at all. -3 is about 75%, -2, 50%, -1 is 25%. We do the smooth pursue and H shape accommodation, then the saccade, which is the fast eye movement. Let's see the video of what I mean by doing this. So the Dr. Volpe and his book with the video, he's talking about observation. I don't know if you hear the sound, but he's observing for what I mentioned, ptosis, proptosis, etc. Now he's closing one eye, and then he's doing the duction, ocular duction, abduction, adduction, supraduction, infraduction. And he will do that, the same thing on the left side. And after that, doing the duction, he will do the vergence, which is when moving both eye together. Now you can do the H shape to observe all the eye direction of the eye movement. I will stop the video here for the sake of the time, and then you will do conversion and then do the saccades. The fast saccades is the fast eye movement. So this is example why we're doing this. The people listening, why you're doing this. So this is a patient who is doing both vergence, trying, look, the eye is deviated inward. So we think this patient has 6 nerve palsy. On H shape examination, you might think of the 6 nerve, but when you close one eye, the patient is able to move in all direction. Look here, the left eye moving adduction, abduction, normal. So there is no problem when you do deductions, but there is a problem when you do vergence. Vergence, the patient might have control over it. So that's why it's good to have the habit to do both ductions and vergence. Each eye separately, ductions, then vergence, which is the H shape. This patient has convergent spasm. She's having a psychiatric problem. Sometimes they can do conversion by themselves. And by breaking the fusion, doing the ductions, you'll see they have normal extraocular movement. And this happened maybe like we saw few cases over the past year, and we do unnecessary examination, MRIs, etc. And without by doing a normal examination, full ductions and vergence, we realize that, well, there is no problem in the third or fourth or sixth nerve. So that's why we do it sometimes. Okay, now coming into alignment testing. So alignment testing, why we do alignment testing? Sometimes it's not clear to us. The patient is complaining of double vision. And when you examine him, you don't see clear third, clear fourth, clear six. You want to see if they are aligned or not aligned. And there are ways of seeing this. I will not dig deep into them, but you need to know them. You need to practice them in every patient in order to understand why we're doing it. So there is a cover and cover, alternate cover. Just I will explain a few things. The concept of esotropia, you'll see the eye here deviated inward. Why it is deviated inward? Because there automatically there is a problem in the left lateral rectus, and then the patient might have 6 nerve palsy. This patient have exotropia, that means outward, deviated outward. This patient might have 3rd nerve palsy. This patient have hypertropia, so the left eye is higher than the right. The patient seeing double. Hypertropia might happen in cases of 4th nerve palsy. Remember, 4th nerve palsy cannot look inward and downward. So let's show a video just to. This patient have double vision. When you cover one eye, deviate inward, and when you uncover, deviate outward. So the patient have esotropia, and then you can analyze it later on. What's the problem? Esotropia then the patient have sixth nerve palsy. So this needs a practice, but this is a way of misalignment. Another way of misalignment, which I like, is doing Maddox rod. I carry this Maddox rod with me instead of the hammer with the time. Hammer, I can't find it with the residents, but this one I cannot. Not always I find it. Why I carry this? So I carry this and I put a line in the front of the patient right eye and I shine a light. So this, by doing this, the patient will see with the left eye the light, and with the right eye he will see the line. And by simple question, I can ask them, is the line on the right, on the lights? They are on each other. Then there is no deviation. Is the line above for vertical deviation? If there is I do it like this. So the patient will see a red line, and ask the patient if you see them on top of each other. If you don't, then they have hypertropia. So that's the degree. I mean, that's a way, another way of knowing misalignment. The easiest way is to shine the light on the patient eye. For example, in Hirschberg test, here it's the light reflect in the middle of the pupil. So this means it's looking at the light. Here you can see the light. The eye is deviated inward, so esodiviation. So the patient having left sixth nerve palsy. So this again, the misalignment ways is something that you need to do it by with the time. I mean, after doing the examination, it's better when you examine the patient by patient. You do one of them, two of them, until you get the sense of how to do them, and then you will benefit, inshallah, on the long run. Sometimes we use a prism. When just prism is something that shifts the light. So if the patient see double vision because of ocular misalignment, okay, so we can bring this and shift the light so they can see single. So we use this sometimes and put it in patient glasses in cases of irreversible nerve palsy, so the patient can see single. And in some of the cases. Okay, I can see some reading. All right. So let's move on to the next part of the session into cases. So we took the history, knew the important part, physical examination, and now moving into cases. So the first case, we have a 72 years old presented with double vision for 5 days. The patient has binocular double vision, disappear when cover either eye. And this is for us. It's horizontal. Okay, now you're thinking, oh, okay, so we'll go to the horizontal. The image gets separated more when you look far and to the left. Okay, far, that means the patient will look far. That means to abduct both eyes. We don't know now. It is abduction left or right, sixth nerve palsy, but more to the left. That means by history, it sounds like sixth nerve palsy. He reported history of headache. Okay, that's maybe a red flag, but no jaw claudication, fatigue, or weight loss. Okay, that's I'm saying, giant cell arthritis. This is the patient image. We can see here there is ptosis in primary gaze, but when he look to the left, which is the area that I am suspecting that there is a sixth nerve palsy, we can see a limitation of abduction. So the patient is having sixth nerve palsy. Few words about sixth nerve palsy. It causes esodiviation or worse on one side. So the deviation is worse when you look to the left. When you look to the right, might be ortho or no esodiviation. The most important part is this can be a false localizing sign due to increase intracranial pressure. So it goes from the pontine and goes against the petrous temporal bone, then go to the cavernous sinus, superior orbital pressure. So if there is an increase in intracranial pressure, they might present with pure sixth nerve palsy, thought to be that's the push against the petrous bone. So that's why you call it false localizing, because when you do MRI, you don't see a mass. It might be due to increase in intracranial pressure, not because of the mass pushing on the sixth nerve, and can be due to different causes. But the most common cause, I would say, is secondary to microvascular diabetes, sixth nerve palsy. But again, we need to rule out other causes such as giant cell arteritis. But the bottom line here, um, again, with this approach, I mean, you already took the history. There is no weakness, no etc. So no brainstem problem. It's secondary to intracranial pressure. You can see it in pseudotumor cerebri or a brain tumor, and can be secondary to a pressure in the cavernous sinus or etc. This patient presented also with binocular double vision. She's looking to the right. You can see limitation of adduction. So when she looks up, there is a limitation of supraduction. Left is normal. There is ptosis, and she cannot look down. And this is a case typical of third nerve palsy. So third nerve palsy, if you point at the third nerve, of course, it runs through the brainstem. And here, when taking the history, of course, you ask about the weakness because the pyramidal tract passes near the third nerve. It goes between posterior cerebral artery and superior cerebellar artery, and beside the posterior communicating artery, in which it can be compressed by aneurysm. Therefore, I mean, most of you by now know the first thing reflects when you see third nerve palsy, you need to rule out aneurysm. Which artery? PCOM aneurysm. Then it joins the cavernous sinus. It lies on the wall of the third of the cavernous sinus, and then goes to superior orbital fissure before dividing into two parts, supplying all the muscles of the eye except lateral rectus and inferior oblique. So, what are the causes of third nerve? Upon looking at all causes, just I want you to look at the causes at the later decades of life. Um, Aneurysm is not the most common, but the most serious cause that you need to be ruled out in the emergency room. The most common also microvascular. You can see it here in green. Another thing that you need to pay attention to is giant cell arteritis. So, if the patient coming to the emergency with third nerve palsy, always ask about giant cell arteritis. Do ESR CRP, it's just blood test. And of course, do not forget lately, I mean, it can be myasthenia and that's a differential diagnosis. Um, and then say, okay, if everything is negative, it can be microvascular, and microvascular like the secondary to diabetes, it approve usually within 3 to 6 months. So the eye deviate outward and downward. This is typical, and the pupils dilate. This is typical, but not always the case. So ptosis, look for ptosis and dilated pupil because supply the parasympathetic pathway of the pupil and the levator superioris, and pay attention at this and the distribution of the pupillary fibers at the third nerve itself. Yani the third nerve, the pupillary fibers lies at the periphery. So when you have compressive lesions, when you have compressive lesion like aneurysm, and it's okay, you will have the pupils affected first. So here you need to rule out aneurysm and to do CT angiogram. Let's say that you do not have the pupil is not involved, sparing the pupil, and the third nerve involved. So in this case, you cannot rule out aneurysm. There is a still chance that it can be aneurysm. So I would do CT angiogram, make sure it's not an aneurysm, but you are more comfortable saying that the patient having, for example, all complete third involvement except the pupillary. So this is microvascular. Should I discharge the patient? I would say no, because still, through a few cases, you can miss an aneurysm. So do CT angiogram in an emergency setting. Okay, moving on into the fourth case. This is a 30 years old man presented with vertical double vision. Okay, diagonal double vision, persistent, not fluctuating for 3 days. I'm saying just, okay, this is not clearly myasthenia. No other neurological symptoms, no trauma. So vertical double vision, now you have your differential diagnosis. Is it a fourth nerve palsy, thyroid eye disease, of the myasthenia gravis, or stroke, skew deviation, or third nerve palsy؟ طيب third nerve palsy عرفناه, we saw it. يعني all the muscles are controlled by third nerve, you can diagnose it. Thyroid eye disease, you can identify it by looking at the patient's eye proptosis. Myasthenia is not fluctuation, does not rule out myasthenia. So let's move on to examination. So this patient having fourth nerve palsy, why is that? Just I wanna, when the patient, what the fourth nerve does? Fourth nerve, it pulls the eye downward and inward this way, and like the arrow. So when the patient having left fourth nerve palsy, it will be worse when he look to the right. Left fourth, well, why is worse when you look to the right? Because it's not working on adduction, so there is no muscle pushing down and downward. So the left hypertropia worse on right gaze and left head tilt. Why left head tilt? Because the fourth nerve also does intorsion. So with left head tilt, your eyes will be intorted, and if they have fourth nerve palsy, it will not. So this is the rule of fourth nerve palsy, which is hypertropia, worse on left, right, left hypertropia, worse on right gaze, and left head tilt. Let's see at this fourth nerve palsy. So this patient looking to both sides, look at the right eye again. Let me repeat it, and look at the right eye when the patient look to the left. Look now, the right eye is higher, is because nothing pulling it. It's worse, the hypertrophy when look to the left. But what happened with the look to the right? Here, it's not clearly worse that the right eye is higher than the left. Okay, now let's take an example of the cover and cover test, and you'll see how the patient eye is higher. This down, this up, came down, up, came down. So this is hypertropia. Now it's up and came down, but look when he looked to the left, it's so much higher. It's very obvious. And with the right head tilt, very obvious. And the right going down and left go up. And with the left head tilt, it is there, but not as obvious for the right. And this is the fourth nerve palsy. A few words about the fourth nerve. So fourth nerve is exiting from the back. So the left fourth nerve going received from the left superior oblique receive innervation from the right fourth nerve right nucleus. So it does this reverse, and this is thin and long. Take a thin and long course, and that's why in cases of trauma, head to the head, they might have double vision affecting the fourth nerve. So because of the course. So most common causes is trauma, microvascular ischemic, and diabetes, but the most common cause is congenital. The patient born with fourth nerve palsy and decompensate and when they are getting older. This you can see this patient is right. I mean, not only the eye, even the eyelid is higher than the other eyelid in patients with congenital fourth nerve palsy. Always, if you suspect fourth nerve palsy, ask the patient, do you have an old picture? And when you see them when they're in the school, with elementary school, all with his friends, he's looking his eye. He always tilt his head to compensate for the fourth nerve palsy. They can come present to you like this. Till head is tilted. And this is a way also in Maddox Road that you can see the separation between the light and the line, how is it worse on left gaze. And then in this case, I'll say that the patient has, let's say that you don't have Maddox Road. You will just, during, when you do this smooth pursue, ask the patient, do you have double vision? He said, yes. Okay, the eyes, and when you move your finger to the left, is it worse now? They said, okay, yes. Then move the head, tilt it to the right. Is it worse now? Separate it or this? tilt his head to the right and left. See which separation is indicating more, and by this will diagnose fourth nerve palsy. Let's move on to the last case today. This is a 56 years old female presented with double vision to our hospital. And let's headache and double vision. Okay, let's see the video. I'm asking the patient to look down. Okay, moving left, not moving, up here, up and down, up, not moving, and right and left is not moving. Here and right and left is not moving. See, it's not moving at all. So what's the problem here? So when you think about this, go to your anatomy. Okay, so it's not third, not fourth, not sixth. Well, it's not cavernous sinus, and both cavernous sinus might be affected, maybe, but the patient, most of these patients will be having a lesion there in both cavernous sinuses, a differential diagnosis. But what we call this, we call it ophthalmoparesis. The patient not able to move the eye. So when when you review our anatomy, it can be either due to nerve problem, neuromuscular, or muscle. All right. So nerve problem, what nerve problem can cause this? It's not a specific nerve, but in some of the conditions, such as Miller-Fisher or Guillain-Barré syndrome, you might have this. Myasthenia gravis, it is in the differential diagnosis. So it can be myasthenia gravis. What else? Thyroid eye disease. It can be thyroid eye disease, but not there's no proptosis here. But one of the differential diagnosis of ophthalmoparesis. Supranuclear causes, though, well, is it because of cortical problems? They cannot move because the patient's having frontal eye field problem. Then what we did here, we tried to do vestibulo-ocular reflex. Is it moving? It's not moving. So it is not supranuclear. We tried two pathway now, and it's not moving. So this is a case of ophthalmoparesis that's not moving. Just a second. One second. So on further history, so the patient has binocular double vision for 5 days, vertical, not worse in any direction. So I'm not getting any help here. But again, ocular pain, no nothing, no diurnal variation, no weight loss. She's diabetic, has history of recent cold. So if one eye is not moving at all, so then it will localize to cavernous sinus or orbital apex, but both eyes might be. We spoke about myasthenia or carcinomas meningitis. Divide your differential diagnosis. Do not panic. Divide it in nerve, neuromuscular, then muscle, nerve, Miller-Fisher syndrome, neuromuscular botulism, or myasthenia gravis, muscle, thyroid eye disease. So those are our differential. What we are going to do next? Out of these, those are very important treatable causes of the similar case. What I didn't mention here is the Wernicke encephalopathy or thiamine deficiency. So something in the differential diagnosis in addition to myasthenia, Miller-Fisher, etc. We did the brain MRI, it was normal. We did lumbar puncture, the protein was increased. And then the blood tests, GQ1B, which is something can be seen in cases of Miller-Fisher, like cases similar to Guillain-Barré syndrome. Uh, the patient was treated with IVIG and her vision recovered fully. So that's one of the treatable causes of ophthalmoparesis. And then by this case, we can approach ophthalmoparesis. It is supranuclear versus infranuclear. Uh, in infranuclear, nerve, neuromuscular, and muscle. Supranuclear, if we do the VOR and it is still not moving, it's not supranuclear. That means still the problem will be infranuclear. And from the infranuclear, we nerve, we mentioned our causes, and the patient was treated here. So by looking at this case, we'll say if you go systematically, then you will be able to reach to your diagnosis. In summary, if you have a case of double vision, of course, the first question, the key question is to look if it is monocular versus binocular. If it is binocular, look if it is horizontal versus vertical. Take a good history. Worst distance, think of sixth nerve. Worst looking down, to think of fourth nerve. Head tilt, fourth nerve or skew deviation. Fatigability, suggesting myasthenia. After that, examine the patient. Is it a third or fourth or sixth nerve palsy? And if when you localize your problem, order your appropriate different investigation, a CTA or MRI. If does not follow the rule or you're still confused, where is it? Just remember your anatomy, infranuclear versus supranuclear, and try to look at back at the patient, see what is the deficit, and then to localize where is the problem. Always consider myasthenia gravis in your differential diagnosis of double vision. Remember the treatable causes of ophthalmoparesis, thiamine deficiency, myasthenia gravis, Miller-Fisher syndrome. CT angio should be done in all cases of third nerve palsy, especially if the pupil is involved. And if not, also I would do CT angiogram. ESR-CRP should be done to rule out genital arteritis if suggested by history. And by this, I will conclude my 51-minute lecture. Thank you very much for your attention, and I'm happy to receive any question.
السلام عليكم دكتور.
عليكم السلام ورحمة الله.
دكتور، أنت قلت ال GCA is an important differential to rule out.
صحيح. An elderly
ولاحظت
patient.
لاحظت إنه more than one cranial nerve. فكيف ممكن يأثر يعني patient present as oculomotor nerve palsy ولا sixth nerve palsy وممكن يكون GCA بكل الأحوال؟
طيب GCA might present with vision loss. هذا typical affecting the second cranial nerve. يعني يصير patient they may present with vision loss, but it also can present with any like third nerve ولا sixth nerve. So بعد after you localize third nerve, okay, now patient having third nerve palsy, خلاص you come down to your differential diagnosis. لا تنسى الجي سي اي من الديفرنشال diagnosis. ليش؟ لانه you might diagnose it at only as early as third nerve palsy and prevent further complications of the eye, stroke ولا eye vision loss and etc. فلا تنسى الديفرنشال diagnosis للثيرد نيرف palsy. one of them الجانسر arteritis احنا شفناه انه مو كثير، شويه بس من patient in the age of 70 وفوق. بس انا اقول ESR-CRP it's easy test to be done in the emergency room, easy to question to ask the patient to rule out this possibility.
يعطيك العافية دكتور، شكرا.
أهلا وسهلا، هيا.
دكتور أنا عندي سؤال إذا ممكن.
تفضلوا، بعدين بشوف الأسئلة. تفضلي، مين معنا؟
اسمي سندس. كنت أبغى
حياك الله.
أسأل عن، الله يحييك ويبقيك، عن آخر كيس. هل السبب الريسنت كولد ولا ما له علاقة؟
A recent cold is a risk factor for a patient to have Guillain-Barré، صح؟ يعني دائما نسأل السؤال هذا إذا
أيوة.
patient عنده Guillain-Barré، فغالبا له علاقة في حالة المريضة حقتنا لأنه auto immune condition، فكان له علاقة. نعم. It's a post-infectious process. One of them is يعني Miller-Fisher treatable. كان recovered fully.
شكرا دكتور.
أهلا وسهلا.
Is there any other questions?
إذا في أسئلة أنا قاعد أشوف في الشات، تبي نسأل أجاوب منها ولا في أحد بيقول verbal question؟ طيب خلينا نجاوب بعض الأسئلة على ما إذا في أحد عنده أسئلة. Doctor, do you recommend to do each exam for each eye with the other eye covered? I recommend to do each eye to be examined separately. You can do it like a Z, like abduction, adduction, subduction, infraduction, each eye, and then you do the H with both eyes. That's what I recommend. ما طبعا you can عادي you can discover the problem with H shape على طول. بس what I recommend is do each eye separately. Question, when you see a third nerve palsy with a normal pupil, think of microvascular ischemia, but still monitor closely. If the pupil is dilated, always to rule out aneurysm first. So coming into that, so if you see third nerve palsy, pupil involved, خلاص اتفقنا rule out aneurysm. If the pupil is not involved, is it partial؟ يعني مو كل النيرف involved. إذا partial, you still need to do CT angiogram to rule out aneurysm. إذا complete كل النيرف is affected ما عدا البيوبل، هذه most likely to be microvascular. بس في study يعني أخيرا يقول لك at least 13 to 15% of patients you might miss an aneurysm with pupil sparing. So الحين I would recommend for all patients to do CT angiogram. صح انه likely ومو likely يعني بس انه let's do it for all patients. طيب وش stroke elevated? What's the cause of the last case? Okay. What's the idea of head tilt with examination? Head tilt, okay. When you tilt your head to the right, the eye automatically will intort to the left. يعني will move the other side. يمكن I showed it in one of the pictures. يمكن اسويها ب one of the pictures. بسويها بوريكم اياها. او so I showed it with fourth nerve palsy. يعني تخيل انتم نحن وانتم جالسين لفوا راسكم يمين, eye will intort and the function of fourth nerve will do intorsion, but if it's affected it will not intort, so that patient will have more hypertropia when you tilt to the right side. To compensate for this, the patient will tilt their head to the other side. يعني يجيكم شوية مايل راسه, وهذا suggest fourth nerve palsy. تمام. اوكي. طبعا thank you for some of the comments. تمام. ما ادري اذا في اي اسئله ثانيه.
يعطيك العافية دكتور. Thank you so much for such an excellent and enriching lecture. We are truly grateful for the time and effort. It has been truly an honor to learn from your knowledge and experience. On behalf of the club, I extend our deepest thanks once again to Dr. Faisal for his generous contribution and to all of you for attending and engaging with us tonight. Your participation is what makes these events truly meaningful. Thank you all. ويعطيك العافية.
Thank you. شكرا. Thank you very much for the organization, for your attendance. Good luck إن شاء الله.